Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 199 of our Pharmacotherapy MCQ series, which majors in cardiology. And the first question reads, WPW, a 67-year-old male patient is referred to the hypertension clinic by his general physician. He has a past medical history significant for type 2 diabetes mellitus, and angina. The patient had a myocardial infarction 1 year ago and has been chest pain-free on the current regimen comprising of clopidogrel 75 mg and aspirin 81 mg daily after drug-eluting stent placement then. Despite the current regimen of metoprolol 100 mg orally twice daily, and lisinopril 40 mg orally once daily, WPW's blood pressure is consistently in the 150s systolic and 80s diastolic, and his heart rate is 64 beats per minute. His ECG is normal. His potassium levels are 4.2 milliequivalents per liter. His serum creatinine is 1.1 mg per deciliter. He has a TC of 204 mg per deciliter, an HDL of 40 mg per deciliter, an LDL of 78 mg per deciliter, a TG of 220 mg per deciliter. Other medications include simvastatin 40 mg at night and metformin 850 mg orally after breakfast and dinner. His HbA1c is 7.3%. So my question to you is, which regimen change would be the most necessary to address WPW's cholesterol? Would it be A. No change is necessary, or B. Initiate evolocumab 140 mg subcutaneously every other week, or C. Add ezetimibe 10 mg orally once daily, or would it be D. Change simvastatin to atorvastatin 40 mg at night? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Change simvastatin to atorvastatin 40 mg at night. High-intensity statin therapy is recommended indefinitely in all patients with clinical atherosclerotic cardiovascular disease. That makes answer D correct. Current guidelines recommend starting high-intensity statin therapy as soon as possible with a soft LDL target of less than 70 mg per deciliter. Because this patient's LDL is near that target, changing simvastatin to atorvastatin 40 mg daily may be all that is necessary to improve his cardiovascular risk. Adding ezetimibe can reduce LDL further and have a modest effect on cardiovascular event reduction. However, changing the statin to the highest intensity should be tried first. That makes answer C incorrect. This patient should not require the addition of PCSK9 inhibitors to reach his LDL goal. That makes answer B incorrect. Intensifying his statin regimen is most appropriate according to the evidence-based guidelines, therefore, a change is necessary. That makes answer A incorrect. Please advance to the next question. And the next question reads, RAO, a 75-year-old male patient is admitted to the medical intensive care unit with respiratory failure suspected to be due to an exacerbation of chronic heart failure. He has a past medical history significant for atrial fibrillation while taking dofetilide. During admission, RAO is given a diagnosis of community-acquired pneumonia. He is treated with levofloxacin. While recovering from his illness, the patient develops delirium overnight on his third hospital day and is treated with repeated doses of 5 mg of IV haloperidol. On rounds the next morning, the telemetry system alarms, and the patient is in a rhythm consistent with polymorphic ventricular tachycardia, abbreviated as VT. He is unresponsive without a pulse. So my question to you is, which of the following would be the most appropriate initial action after high-quality cardiopulmonary resuscitation (CPR) in RAO's clinical scenario? Would it be A. lidocaine 1 to 1.5 mg per kilogram IV push, or B. 200 joules biphasic defibrillation, or C. amiodarone 300 mg IV push, or would it be D. magnesium sulfate 2 grams IV push? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. 200 joules biphasic defibrillation. The patient appears to be in pulseless VT, likely because of QT interval prolongation from multiple QT prolonging medications. According to the Advanced Cardiac Life Support Guidelines, immediate defibrillation is indicated for pulseless VT or ventricular fibrillation arrest after CPR initiation. That makes answer B correct. Although magnesium is ultimately indicated for this patient, it does not replace defibrillation as the immediate step to try to restore circulation. That makes answer D incorrect. Amiodarone and lidocaine are not indicated in this immediate interval. That makes answers C and A incorrect. Please advance to the next question. And the next question reads, ASA, a 53-year-old female patient is admitted to the cardiology ICU with a 3-week history of fatigue and shortness of breath. She has a past medical history significant for non-ischemic cardiomyopathy. Her last left ventricular ejection fraction was 25%. She also suffers from hypertension. She has breast cancer in remission after chemotherapy and radiation. She requires intubation because of hypercarbic respiratory failure. Her initial vitals include a blood pressure of 70 systolic and 40 diastolic. The cardiothoracic surgeon places a pulmonary artery catheter at the bedside which shows the following: pulmonary artery pressure 50 systolic and 30 diastolic, pulmonary capillary wedge pressure 32 mm of mercury, a cardiac output CO of 2.3 liters per minute, cardiac index of 1.3 liters per minute per meter squared, systemic vascular resistance 1300 dynes per second per centimeter to the power of -5, and mixed venous oxygen saturation of 31%. So my question to you is, which of the shock syndrome listed below is most consistent with this presentation? Is it A. undifferentiated shock, or B. cardiogenic shock, or C. septic shock, or is it D. anaphylactic shock? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Cardiogenic shock. This patient presents with signs and symptoms consistent with cardiogenic shock, as evidenced by her hypotension and severely depressed CO as measured by the pulmonary artery catheter as well as by her low mixed venous oxygen saturation. That makes answer B correct. Her presentation is not consistent with vasodilatory shock, which could be anaphylaxis or septic shock, because her systemic vascular resistance is relatively normal. That makes answers D and C incorrect. Her shock syndrome is also not undifferentiated, given her clearly reduced CO. That makes answer A incorrect. Please progress to the next question. And the next question reads, regarding the clinical scenario above, which of the vasoactive therapies listed below would be the most appropriate for ASA's initial treatment? Would it be A. synthetic angiotensin 210 nanograms per kilogram per minute infusion, or B. fluid resuscitation with 1 liter of crystalloid, or C. dobutamine 5 micrograms per kilogram per minute infusion, or would it be D. phenylephrine 0.01 micrograms per kilogram per minute infusion? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. dobutamine 5 micrograms per kilogram per minute infusion. This patient presents with signs and symptoms of cardiogenic shock. As such, an inotropic therapy designed to directly increase CO, e.g., dobutamine, may be selected as first-line therapy, though an adjunctive vasopressor may initially be needed to raise mean arterial pressure. That makes answer C correct. Fluid resuscitation would not be indicated and would likely be harmful for this patient with clear evidence of intravascular volume overload, as evidenced by her PCWP reading and hypocarbia requiring intubation. That makes answer B incorrect. Pure afterload increasing therapies such as phenylephrine and angiotensin II are not indicated in cardiogenic shock and may further depress CO. That makes answers D and A incorrect. Please progress to the next question. And the next question reads, which of the hemodynamic parameters listed below is the most characteristic of a patient with bacteremia and septic shock? Is it A. increased pulmonary artery pressure, or B. decreased systemic vascular resistance, or C. increased cardiac output, CO, or is it D. increased heart rate? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. decreased systemic vascular resistance, or C. increased cardiac output, CO. Septic shock is described in this scenario, which is a type of vasodilatory shock. The primary variable affected is the reduction in systemic vascular resistance. That makes answer B correct. Increased CO and heart rate are compensatory mechanisms to try to increase output to offset pressure reduction because of a reduction in vascular resistance. That makes answers D and C incorrect. Pulmonary pressure is not usually affected by sepsis. That makes answer A incorrect. Please advance to the next question. And the next question reads, RAL, a 45-year-old male patient presents to your accident and emergency department. His chief complaint is chest pain. He has no significant past medical history. His ECG shows an ST segment elevation in leads V1 to V3. The cardiac catheterization laboratory is activated for an ST segment elevation myocardial infarction. His initial vitals include a blood pressure of 210 systolic and 105 diastolic, and a heart rate of 91 beats per minute. So my question to you is, which of the regimens listed below would be the best initial therapy for RAL's BP before cardiac catheterization? Would it be A. hydralazine 10 mg IV push, or B. nicardipine 5 mg per hour infusion, or C. nitroglycerin 10 micrograms per minute infusion, or would it be D. nitroprusside 0.5 micrograms per kilogram per minute infusion? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. nitroglycerin 10 micrograms per minute infusion. Because the patient appears to be experiencing an acute myocardial infarction, nitroglycerin is the best choice for his initial therapy because of its ability to lower preload and enhance coronary vasodilation in addition to lowering blood pressure. That makes answer C correct. Nitroprusside is less preferred in this setting because of its potential to decrease coronary perfusion. That makes answer D incorrect. Nicardipine and hydralazine are also less preferred in the setting of myocardial ischemia because of their potential for reflex tachycardia, coronary ischemia, and lack of concomitant benefit in the setting of infarction. That makes answers B and A incorrect. Please advance to the next question. And the next question reads, ZPA, a 67-year-old male patient presents to your cardiology clinic with a blood pressure of 180 systolic and 110 diastolic, and a heart rate of 100 beats per minute with concerns of sharp, stabbing chest and back pain. He has a past medical history significant for hypertension. His CT scan immediately reveals a type A aortic dissection. So my question to you is, which of the regimens listed below would be the most appropriate therapy to initiate now? Would it be A. hydralazine 20 mg IV push, or B. nitroprusside 0.5 micrograms per kilogram per minute infusion, or C. esmolol 500 micrograms per kilogram bolus, followed by a 50 micrograms per kilogram per minute infusion, or would it be D. enalaprilat 1.25 milligrams IV push? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. esmolol 500 micrograms per kilogram bolus, followed by a 50 micrograms per kilogram per minute infusion. Aggressive heart rate and anti-impulse control is first-line therapy to reduce shear stress on the aortic dissection. Therefore, esmolol is the best available option of the choices available. That makes answer C correct. Nitroprusside may ultimately be indicated but is second-line therapy to esmolol to further reduce blood pressure and may cause reflex tachycardia when used as a single agent. That makes answer B incorrect. Hydralazine and enalaprilat are not preferred in the setting of an aortic crisis because of their inability to rapidly titrate the effect of therapy and the potential for worsened tachycardia with hydralazine. That makes answers D and A incorrect. Please proceed to the next question. And the next question reads, SDA, a 25-year-old female patient presents for evaluation of progressively worsening shortness of breath with activities of daily living. She has a past medical history significant for hypothyroidism and asthma. SDA reports that these symptoms have occurred with minimal activity such as completing household chores over the past few weeks. Regarding her family history, SDA's mother was diagnosed with pulmonary arterial hypertension, abbreviated as PAH, in her 30s. Diagnostic studies included HIV-negative, hypercoagulable and connective tissue disease workup negative, genetic screening positive for bone morphogenetic protein receptor type 2, abbreviated as BMPR2 mutation. A transthoracic echocardiogram revealed left ventricular ejection fraction of 60% and mildly reduced right ventricular function. Her right heart catheterization showed right atrial pressure 12 mm of mercury, mean pulmonary artery pressure 60 mm of mercury, pulmonary capillary wedge pressure 10 mm of mercury, cardiac index 2.8 liters per minute per meter squared, pulmonary vascular resistance 11 Wood units. Her CT scan of chest was unremarkable, and ventilation perfusion scan low probability for chronic thromboembolic pulmonary hypertension. Vasoreactivity testing with inhaled nitric oxide was negative. Regarding her vitals, the blood pressure at this visit is 110 systolic and 75 diastolic, and the heart rate is 92 beats per minute. Her pertinent labs are within normal limits. Her current medications include salbutamol inhaler 2 puffs 4 times daily PRN, levothyroxine 100 mcg in the morning, and a multivitamin 1 tablet once daily. So my question to you is, which of the following is the most likely etiology of SDA's PAH? Is it A, drug-induced, or B, heritable, or C, associated with heart failure, or is it D, idiopathic? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B, heritable. Answer B is correct. The patient's strong family history of PAH, that is her mother, and the confirmation of the BMPR2 genetic mutation make heritable the most likely cause. The patient cannot be considered to have idiopathic disease when other causes have been identified. That makes answer D incorrect. Heart failure as a secondary cause of pulmonary hypertension is considered World Health Organization functional class WHOFC2, that is pulmonary venous hypertension. That makes answer C incorrect. Finally, no drug-induced causes were identified in this case. That makes answer A incorrect. Please proceed to the next question. And the next question reads, regarding SDA's case above, which of the following best reflects her WHOFC? Is it A, 4, or B, 3, or C, 2, or is it D, 1? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B, 3. Answer 3 is correct. The patient's clinical presentation is most consistent with WHOFC3 symptoms, given her difficulty breathing with minimal activities such as household chores. That makes answers D, C, and A incorrect. Please proceed to the next question. And the next question reads, regarding the case of SDA above, according to the 6th World Symposium on Pulmonary Hypertension Guidelines, which of the medications listed below would be best considered as SDA's initial therapy? Would it be A, Sildenafil 20 mg orally thrice daily and macitentan 10 mg orally once daily, or B. Tadalafil 20 mg orally once daily, or C. Inhaled nitric oxide at 20 ppm, or would it be D. Diltiazem controlled release 240 mg orally once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Sildenafil 20 mg orally thrice daily and macitentan 10 mg orally once daily. Initial oral combination therapy is recommended in patients with low or intermediate risk features. This combination typically includes a phosphodiesterase type 5 inhibitor and an endothelin receptor antagonist. Diltiazem would not be an option because the patient had a negative vasoactivity test. That makes answer D incorrect. Inhaled nitric oxide would only be used to conduct a vasoactivity test. That makes answer C incorrect. Initial monotherapy is only recommended in select patients, e.g., long-term treated patients with stable, low-risk profile, very mild disease, contraindication to or unavailability of combination therapy, none of which fits this patient's clinical presentation. That makes answer B incorrect. Please advance to the next question. And the next question reads, which of the counseling points listed below would be most appropriate regarding macitentan? Would it be A. teratogenicity with the need for monthly pregnancy testing and backup contraception, or B. monitoring for bleeding, or C. vision changes and regular eye examinations, or would it be D. blood pressure monitoring for dizziness and lightheadedness? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. teratogenicity with the need for monthly pregnancy testing and backup contraception. Answer A is correct. All endothelin receptor antagonists, abbreviated as ERAs, are teratogenic and require baseline and monthly pregnancy testing according to their risk evaluation and mitigation strategies programs. Backup contraception is advised because ERAs also decrease the effectiveness of oral contraceptives. Hypotension is not a concern with ERAs, because it is with infusion prostacyclin therapy. That makes answer D incorrect. Vision changes have been associated with a phosphodiesterase type 5 inhibitor. That makes answer C incorrect. Bruising and bleeding may occur with prostacyclins. That makes answer B incorrect. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 200.